I want to welcome everyone to our Digital Health Insights Fireside Chat. Today, we'll be discussing how data and technology can help build better care workflows with a focus on the burden of cardiac telemetry overuse in med-surg. I'm your host, Wendy Almeida, the Managing Editor of Digital Health Insights. But before we begin, I'd like to cover a couple of housekeeping items. There is a chat box icon at the bottom of your screen. This is where you can communicate with us if you have any technical issues with our platform. I also want to note that we will be sending a link to this full recording to all registrants, as well as an additional white paper about the research we'll be referencing and discussing today. You can also use the chat box to ask our guests a question at any time. We'll be answering audience questions, but we'll be getting to that a little bit later in the conversation today. So without further ado, I'd like to introduce our guests. Joining us today is Dr. Kannan Mutharasan, Medical Director and Cardiologist at the Bluhm Cardiovascular Institute at Northwestern Medicine in Chicago. He is also an Associate Professor of Medicine at the Feinberg School of Medicine at Northwestern University. Also with us today is Angela Murray, the Executive Director of Global Health Economics and Outcomes Research at Baxter Healthcare. So to get us started, Kannan, can you tell me a little bit about yourself and the Bluhm Cardiovascular Institute and your role there?
Sure. Thanks so much. And thanks so much for the invitation. I'm very excited to be here with everyone today to talk about telemetry, because I think it really encapsulates a lot of the cross currents that are impacting healthcare, technology, the Great Resignation, use, misuse, overuse of things. So I'm really looking forward to the conversation. So Northwestern Medicine is a network of now 11 hospitals. Bluhm Cardiovascular Institute is our cardiovascular institute that spans all those campuses. I spent about 5-6 years downtown as medical director of central telemetry, and now have recently taken on a role at one of our community hospitals, Palos Hospital, directing our cardiovascular enterprise here.
Great. And Angela, can you talk a little, you've done an extensive literature review about telemetry. Can you tell us a little bit about your work and what the literature has sort of uncovered about clinicians' understanding and practices of following telemetry guidelines?
Sure. Yeah, the work at Baxter is we focus a lot on what is the burden of the condition or the burden of the problem, and then try and identify through the literature how we might solve those problems through the use of our technology. I think we have a variety of technologies at Baxter looking at patient monitoring and alarm fatigue and management, and we were hearing a lot about the issue of telemetry misuse. So we thought we'd dig into the literature to kind of understand a little bit more about the problem. And what we have found, there's many areas, but a couple of the areas that I think are interesting starting out of the gates is that about 50% of clinicians are unaware, or less than 50% of physicians are aware of the 2017 guidelines based on what the literature is telling us. Now, more may be available. Some of that literature was published a few years ago. About 12 to 73% of patients, so there's a big range there of patients that are on telemetry, are not clinically indicated for telemetry. And about 65% of telemetry orders are extended beyond the period that they should be ordered for. So they're typically should be ordered for 24 to 48 hours. So if you think about a patient that's in the hospital for an average of 4.7 days, if they're only supposed to be on it for 24 to 48 hours, that's an additional 2 to 3 days extension on that telemetry time. Imagine the increased workload to the nurses and to clinicians, as well as the number of alarms and alerts that could have been managed or eliminated as a result of that. So those are some of the three areas. Kannan, I don't know if you want to talk about your experience. Does that sound similar to your organization or conversations you've had with your peers?
Yeah, thanks. Maybe I'll start just kind of having everyone sort of imagine themselves, putting themselves in the shoes of a provider, a physician, a advanced practice provider, or a nurse, and just kind of think through, gosh, what prompts people to order telemetry in the first place? And then maybe back into sort of the literature. And I think a lot of us go into healthcare, right? Because we want to make sure that a patient is safe and monitored and watched over. And an instinctual feeling is, well, if they're on telemetry, maybe that's an extra set of eyes kind of looking on a patient, right? Someone's always looking at the heart rate. That heart rate is being monitored, arrhythmias are being monitored. A lot of telemetry systems also look at respiratory rate. So you feel like there's an eye in the sky that's double checking on my patient because my patient is important to me. And what it probably feels like is, well, this is sort of a free resource. There isn't a downside to this, right? It's benign. Sure, someone could get a rash by getting electrodes stuck on them, but largely speaking, we're not talking about injuries that ensue from telemetry monitoring. But there's sort of a hidden cost, sort of the tragedy of the commons. Well, and your literature review has kind of uncovered this. There's work and there's time and there's false alarms and there's fatigue and there's burden on the staff that's associated with telemetry that doesn't feel like a burden in that moment of ordering this. So I think there's not a lot of necessarily upfront incentive to withhold, so to speak, telemetry or think about appropriateness of telemetry or think about discontinuing in a timely manner, because it doesn't necessarily feel like there's so much of a downside, and there might be the upside of monitoring a patient. So it does resonate because a lot of times patients will be on have telemetry ordered because, oh, maybe they're sick or their blood pressure is soft. Sepsis is a common reason why patients are ordered telemetry, although it's not necessarily a beneficial thing in these patients. And it really is something where the feeling of want to provide an extra layer of safety for a patient may prompt ordering telemetry, but you don't really capture the full downside of that. And it probably doesn't add so much to the patient's care in terms of safety.
And we often think that more data will be helpful, but there are challenges when we're overwhelmed with data as well. So, Kannan, have you found concerns related to like the patient selection or actual time on telemetry? I know we talked about this a little bit, that, you know, some of the literature is showing this. Like, have you seen, you know, the actual time on telemetry impacting in your practice?
Yeah, so a lot of times what we think about when we're trying to deliver sort of safe and efficient care, a big part of it is also getting rid of pieces of care that aren't helpful to people, right? You know, this idea of de-implementation in medicine in general, and I think telemetry is a nice sort of use case to kind of talk about that, because we do have guidelines now, and there is a decent amount of data around who benefits from tele and for how long. And just to make it really concrete, right? Maybe I could talk about a specific example, patient who comes in with acute coronary syndrome. So they're coming in, they have chest pain, you're worried if it's a heart attack or not. And you get a troponin, you get another troponin. Now you can get one, you know, 2 or 3 hours later and rule the patient out for acute coronary syndrome. At that time, the patient can be discontinued from telemetry. A lot of times that telemetry order stays on for 24, 48 hours, or even until the time of discharge. So I think, you know, we are seeing that extra burden. And to your point, you know, it is extra work for the staff. It's oftentimes a dissatisfier for patients to be stuck with so many things. I mean, they're stuck with telemetry, maybe a Foley catheter, an IV. And so for us, sort of getting rid of these extra things is an important part of our practice.
Yeah. Angela, you had uncovered a study that you had shared with me about 68% of physicians rely more on instinct or experience rather than the clinical guidelines to start telemetry. Can you talk a little bit more about that research that you uncovered about that study?
Yeah, I think it's exactly it, that, you know, they don't necessarily want to follow the specific guidelines and identify the classifications of patients, and that they look at the patient, they assess them, they're well-intended, you know, and they really go based on their past experience and their gut to say, hey, this patient maybe needs it. They may be looking at the overall environment, the care environment, you know, today particularly, you know, we've got shortages across all healthcare workers in the hospital and that, and I think, you know, prior to the pandemic and even today, there's just that feeling that, hey, as Kannan talked about, the fact that there's just this extra set of eyes that allows us to monitor these patients more effectively. I think there's a bit of a misnomer around that. I don't think it definitely does the monitoring that is needed by some of these patients, particularly the patients that we think are the biggest culprits from a respiratory perspective, from a sepsis perspective, and from a GI bleed perspective, is what we've seen in the literature as the biggest culprits of misuse. But I think there's very much that past experience, that physician gestalt, and what it carries over to is the residents as well that are being trained by these experienced clinicians. So you have this perpetuating cycle of more seasoned, more experienced clinicians that are driving the behaviors of these residents as well. So I think it's twofold. It's not only the experienced physicians, but it's the new physicians as well. Kannan, do you agree, disagree, reactions to that?
Yeah, no, and just to pick up on that, I think that's on target, right? There are literature and there's guidance around this, for specific cardiac conditions, whether it's acute coronary syndrome, diuresis of a patient with heart failure, monitoring after coronary artery bypass surgery. If a patient's in the hospital, they might have had a heart transplant or electrolyte abnormalities. There are literature to guide in the 2017 guidelines how long these patients are recommended to be monitored on tele and when safe or reasonable stop conditions are. And the challenge is that there's so many different conditions and different cut points that it becomes very difficult for an individual clinician to remember, oh gosh, is that 24 hours or 48 hours? I mean, it's hard to keep track of that. I can't keep track of that, candidly. And so this is what brings up the notion of digital health and the ability to support clinical decision-making in the electronic medical record or with system processes that prompt people to reevaluate the need for telemetry. So this is the part of, sort of automating the decision support and the thinking in a way that can help really streamline telemetry use. So just to share some of the things that we've implemented at Northwestern, and this is taking cues from the literature. There are big studies done in the mid 2010s at Christiana Hospital and the Providence system of how to do this. And so some of the things that we've done in our EMR, when someone orders telemetry, we ask them to indicate the reason for telemetry, acute coronary syndrome rollout or electrolyte abnormalities. And based on the reason that's selected, because most doctors can understand the reason why they're selecting it, you can remember that, the system then puts in a certain amount of time for which telemetry is authorized, 24, 48, 72 hours, or indefinite. And then what happens at that time where telemetry is about to expire is it prompts the nurse and the physician, hey, telemetry is about to expire. Would you like to just fall off? Do you want to discontinue it? Or do you want to reorder it for another, set period of time? So that sort of coupling of upfront, what is the indication? And then the system remembers how long telemetry ought to be ordered. And the prompting of, do you want to discontinue telemetry? Oh, and by the way, in the EMR, it shows, hey, you know what, sepsis, GI bleed, these aren't indications for telemetry. But of course, we don't restrict physicians from ordering it if they think it's needed, because we want the clinician to be able to order things that they need. That combination of sort of system prompting can help us reduce utilization of telemetry. And we've seen that not only in the amount of patients who go on telemetry, but the length of time upon which people are on telemetry when it's really that, as you nicely put it, Angela, like that length times the number of people that really actually defines the burden of telemetry in a hospital. So my main reaction is yes, and let's build smart digital tools to help people make decisions that are consistent with guidelines.
Right. And Angela, in your research, of how nurses are in direct care, quantify their, workload for a telemetry patient and the increased time. Can you talk a little bit about that?
Yes, this is really interesting. I mean, there's not a lot of studies out there on nursing time, but we were able to dig up a few, and maybe our audience has even more experience around this as well. But wide range. right? And there's been some time and motion studies done around this. And it's hard to tease out in the literature what was actually measured, because they talk about it kind of the daily kind of telemetry activities, so I don't know if that's just monitoring and reading and that, or it's, reacting and responding to alarms and alerts. But the variability is anywhere between 20 to 90 minutes per day per patient on telemetry, which is really significant. If you think about, in some of the literature, you're talking about, in a standard, 200 to 300 bed hospital, 70 med surg base beds, and maybe all 70 beds are, 100% capacity on telemetry. Can you imagine the nurse spending 90 minutes on all of those patients throughout the day? It's overwhelming. How are they able to do the other care that is indicated for the patients if there's that much burden associated with it? So I think it's something that needs to be better evaluated and understood, because to Kannan's point earlier, it's really, it's the sense of benign, that, and there's this safety for the patients, and it's really, there's no consequence other than making sure that this patient stays safe while they're in our hospital and is discharged home to their loved ones. But there's many ways in which it's being impacted, and nursing time is precious today, as all healthcare professionals are, but particularly now with the shortage that we're facing.
Yeah. Oh, sorry.
I was just going to say, I think that's a really great point, Angela, that the amount of time in what we kind of call the care and feeding of telemetry, right?
Yeah.
Well, electrodes fall off, leads become disconnected from electrodes, the battery runs out, the patient, maybe they change their gown and someone loses the telemetry box. All of that stuff takes time. And the other part is, it's not very sort of satisfying work to do all of that, right? If you're a nurse, you're a highly trained professional, you don't, changing electrodes is part of your job, but it isn't the part of your job where you're really engaging the critical thinking that you're trained for. And so when we think about staff retention, especially in this shortage, how do we make work more joyful? How do we get rid of things that aren't as helpful? And maybe ways to reduce unnecessary telemetry utilization could be one of those aspects. Now, the interesting thing is, this doesn't show up on any type of financial metric, right? If you take a typical unit of 30 beds and you say have 6 or 7 nurses staffing that full time, well, you're not going to save enough time with telemetry cutbacks in utilization where you're going to save on headcount and you're going to impact the bottom line of the operational costs of the unit, right? So this is something where if you're looking at this from a purely financial lens, you're not going to see the impact, but this is where that operational lens and that human resources lens and that sense of how do we take care of our people becomes so important, because through that lens, you start to see, well, 15 minutes spent dealing with telemetry that isn't necessary for the patient is 15 minutes where the nurse is not able to counsel the patient on the meaning of their heart failure or the meaning of their coronary disease, or they're not going to have that time to take that one extra walk for the patient, which then is the difference between the patient going to a skilled nursing facility versus home with home health. So a lot of things tied into this. I think one of the challenges that I think for healthcare leaders on this call is, how do you grab that impact and articulate it to leadership within your organization where people say, hey, this is really important for us to do?
Yeah, it's interesting. I was listening to a podcast by Adam Grant, an organizational behavioralist, and he just talked about the fact that you have to not only think about the data, but the picture, right? Create a picture and an image of what this really means as far as the workload and the burden, because numbers are numbers, but as healthcare workers, we have an emotional attachment to our patients and the work that we're doing, and we want to do the best job that we can. And just as you're saying, this creating this joyfulness, and just the mere problems of just trying to find beds, transfer beds, bringing in environmental services people to clean rooms because we've got to get a patient who likely doesn't need telemetry on a telemetry bed, but it creates this churn in the organization that is really unnecessary. So I like the word joyful. Let's bring joy back into work, for sure.
We actually had a question I was just going to ask that an audience member asked or mentioned too about the financial implication, both in equipment, telemetry equipment itself and the beds themselves and, all that goes with it, as well as the, the workload and the staff time that's focused on that. And what is sort of the, people don't like to talk about economic impact when we're talking about patient safety, like those two things are not comfortable conversation to have, even when there's research here that indicates that this particular condition really doesn't call for telemetry. So I'm going to ask you first, Kannan, what do you see as sort of like an economic impact at your organization around telemetry, or what have you, you've implemented some new things, like how has that sort of helped and still made sure to solidify, yes, patients are first, we consider their safety as we make these changes?
Yeah, so Lindsay brings up a great point that there are also hard dollar costs associated with telemetry, right? And it's not just sort of these soft dollars that we're discussing in terms of time and motion on already a fixed headcount. So in our organization, I think I can't remember that, but in central telemetry alone at Northwestern, which is a 900-bed hospital, I think we were spending $20,000 to $30,000 on paper alone, right? Just the telemetry rolls that come off the machine. So digitization of that will be a hard dollar saving there. And that's just the paper, right? That doesn't even include, if you reduce telemetry utilization, all the electrodes that you would save money on, the fact that for your institution, you're going to be leaner in terms of the number of telemetry boxes that you need, each of which comes with a cost, and each of which, let's face it, break down, get lost, and have a limited lifespan. They're not going to make it 10 years or 100,000 miles, right? They're just something's going to happen to them. So replacing those, the management overhead of, making sure that, okay, now we've had to hire, since we have 20% extra telemetry use, now we have to hire a telemetry technician to monitor those 48 beds, which is probably the maximum safe number of beds. And that's not just one FTE, that's a 24/7 operation. So that's 5.2 FTEs. So there are a lot of fixed costs that come into this overutilization of telemetry that people can kind of articulate and say, hey, if we can digitize, if we can use digital health to be smarter about who we're using telemetry on, we can actually streamline and save for the organization.
Yeah, and Angela, what do you see from your perspective of your literature review of the economic impact, and what you're thinking is sort of balancing act between feeling okay about how much you spend on it versus patient safety?
Yeah, and I think there's high variability around the economics, and I think it's as Kannan says, it's the reason is because what's the lens that we're looking at as far as the cost associated with it. Oftentimes it's sunk cost. We've already made the investment of the wiring, the maintenance, and that, so we don't think about that, or we don't include all of that in the studies. The evidence suggests there's a wide range of the cost per day. One hospital said it was $1,400 a day. Another said it was like $35 and change, so wide variability there. I think there's more opportunity to dig into this a little bit. And I think there's more around opportunity costs as well that we need to examine as far as throughput issues, ED waiting times, transfers that are delayed from the PACU organization, or transfers that may be delayed out of the ICU or into the ICU just because we're waiting for telemetry beds and things like that. So there's a variety of costs associated with that. And then, there's hard costs as far as money, and then there's costs associated affecting the patient experience in the organization as well. When you think about patients who are on telemetry, they come into the hospital, they're being monitored, and then if there's a delay associated, or it doesn't come off until the day they're discharged, they're kind of scratching their head thinking, really, am I really ready to be discharged home from the hospital? So that may extend into additional length of stay. There was a really nice study that was done around looking at length of stay, comparing patients who were did not have a clear indication. They were respiratory patients that did not have a clear indication to be put on telemetry. They were put on telemetry, respiratory patients, and they compared the respiratory patients on telemetry without a clear indication to those patients that were not on telemetry, similar patients, respiratory conditions. And they found that those patients on telemetry stayed in hospital an extra day longer than those patients who did not. So matching those patients, they look the same. So there's another cost associated with putting the wrong or inappropriate patients or non-classified patients on telemetry. So there's a whole lot to unpack as it relates to that. And I don't think we've dug into it enough to really understand that economic burden associated with telemetry. And I think it'd be fantastic to do some studies in that area.
Yeah.
Yeah, sorry.
No, I was going to say, I think that's just a beautiful summary of kind of the lay of the land with all of that. I think, the economics, I think also, it feels like, just riffing off one of the questions that popped up on the chat, is telemetry a big enough deal or cost to escalate to the level of hospital leadership to really pay attention to it? It'd be really interesting to hear your perspective, Angela, on that. My gut tells me many organizations, at least in this moment, probably hospital leadership, they're working on how do we reduce reliance on sort of temporary staff and agency, which is really eating into margins. So maybe not in this moment, but I'm curious if in your review you've come across anything or any institutions where this has been prioritized.
It's interesting, Kannan, because as we look at the literature, the publication around the problem of telemetry misuse, over the last 5 years, it is growing exponentially. So that's an indication to me that it is a problem in hospitals. I mean, obviously the pandemic kind of trumped everything else as far as the management and the care of the patients. But it would be interesting. I think once the dust settles a little bit, this is an area and it's an opportunity to more affect. I think we need to think about not just about the telemetry misuse, but the impact that it is having on staffing. There was an interesting study out of Sweden that really talked about the fact that nurses now are spending only about 30% of their time in direct patient care. The other is communication, a lot of administrative activities and that. Now, this is just, one country in that, but it was an interesting study to me. And I'm thinking about, if I break that down and I look at telemetry taking 90% of a nurse's time, and they only have 30% of their time at the bedside, I think it surfaces as, hey, this is something that we should be looking at. And there are a whole bunch of other benefits to reducing costs and reducing the burden on nursing time as well, which are all important topics right now that organizations are facing. So, maybe it's not top of mind, but it potentially should be. And I think that hospitals need to look at their own individual data to determine whether or not it's the right path or the right priority for them, because some organizations may have it nailed and others, they really have an opportunity here.
That's great. I wanted to pick up on one thing, which may take us a little off topic, but I think it's so important that you highlighted it that I just want to expand on it with an anecdote. That idea of how are we using nursing time in the hospital? And, I rounded on patients this morning. I see patients every day, and we all know, and doctors are the same way. We're spending more time at the computer terminal than we are with patients, right? And I think we need to be very thoughtful about what documentation burden we put on staff. As an example, just before we were going to launch this webinar, I got a page from a nurse on the floor that had a patient on telemetry. Heart rate was in the 30s or 40s. Okay, I pull it up electronically. And I didn't have the EMR in front of me but I was on my phone. I asked the nurse, hey, is the patient on any rate reducing agents like a beta blocker? Hold on, let me get into the EMR. And then she whispers like, oh, I hate how slow this is, right? So it takes a minute to pull it up. That's a minute the doctor's waiting, a minute the nurse is waiting. Then we figure out the information. And that doesn't have anything to do with telemetry, but it does have to do with this general idea of extra work and documentation burden. And the less of that we can have, the more efficient and joyful our practices can be.
Yeah. And being able to present the right information to the clinicians at the right time as well. using the technology that we have available to us. There's better opportunities to optimize the communication patterns we have for clinicians and sharing of information, for sure.
Absolutely.
Yeah.
Absolutely.
And this sort of leads me into my question, really for Kannan, about like how do folks build a roadmap to be more strategic and like, developing new telemetry workflows. I mean, you're sort of making this culture shift if you're a hospital that has been sort of, over prescribing, going to request telemetry. And so how do folks like make that cultural shift, deal with with that cultural shift, as well as sort of addressing the patient safety issues and starting making a roadmap there to a new future?
I think it's a great question. I think a big part of it is every organization will be different and just kind of starting somewhere in the conversation. But I think if I were to try to sketch what I think of it as a general template, I think telemetry, like most things in healthcare organizations and really any enterprise, you always want to have what I would call the air game and the ground game. And the air game is like a data framework, a way to sort of digitally capture information on what you're doing with telemetry, whether within your EMR or within an enterprise data warehouse, or maybe if you have a sophisticated package that digitizes your telemetry. Start looking at where what telemetry length of time on telemetry is, what percent of your patients are getting telemetry orders, where are they being ordered from, when are they being discontinued, what time during the day are they being discontinued. Obviously, discontinuing at 10 in the morning for the afternoon bolus of VR patients that need telemetry is much better than 4 in the afternoon. So starting to get a handle on where are your pain points, I think is very helpful. We haven't even touched on, and I think we will talk about the idea of alarm burden, alarm fatigue. What are your key alarms? Do you have your alarms optimized? What units are alarming more? Is there a problem with sort of telemetry hygiene in terms of the stickers? All of this is very ripe for sort of digital data capture, what I would call the air game. But then a really big part of it is sort of that ground game, which is really just that conference room to conference room, constituency to constituency, nursing unit to nursing unit conversation around, hey, this is important for us. We want to use telemetry appropriately. And, what are your ideas to help do that? And really sort of start embedding telemetry appropriateness in the culture. And what we found, Wendy, has been a great forum for that is interdisciplinary rounds that occur at, typically most places 10:30, 11 o'clock after the doctors have had a chance to round, the hospitals have had a chance to round and sit down with the nurses and putting it on the checklist. Just like if a heart failure patient, hey, do they have strict I's and O's ordered? Do they have daily weights ordered? This is part of that. Does this patient need telemetry? So I think that sort of continual emphasis is a really important aspect of this. And I think just kind of knowing where you're going. Hey, we want to either reduce telemetry utilization to this, or this is our outcome metric. I think all of those pieces together sort of help people start to get a handle on improving telemetry utilization to make sure it's more appropriate.
Yeah, and I think really tackling too that whole thought that telemetry is benign, right? How do you think organizations can help shift that thinking? Because I think that's one of the big stumbling blocks, right? We can do all this education and training and create these tools and these technologies, but if we don't get at the heart of how people think about this, what are your thoughts? Do you think that can stymie your ability to move forward? Or
and Angela, you might be cutting in and out for me at least.
Yes.
Oh, sorry.
No, I think you're back. So
You're back.
So if you don't mind just repeating what you just mentioned, I think we lost about 10 seconds of it.
Sure. So I'll try and tighten it up. The just kind of that cultural idea of that technology or telemetry is benign. How do you shift that thinking in the organization?
Yeah, I think it really comes down to helping replace this idea, because it comes down to this idea of sort of safety, or is this patient monitored? I think sort of substituting a habit, or helping people understand that, hey, your patient is still safe, because I think that's the fundamental human need that overutilization of telemetry is really guiding. It's not like sort of a cerebral thing, it's a gut level thing when people are using it and keeping it on. You know, if you're hourly rounding on your patient, if the patient has appropriate vitals intervals, we're not going to miss a decompensation that's important. And for these conditions, certain conditions, this might not be the most appropriate way to monitor them, as you kind of alluded to before, Angela. So I think that's part of it. And then I think another part of it is, you know, just surfacing for people the idea of, hey, what could you be doing if you're not trying to mine the telemetry on this patient, and just helping people say, oh, I could get to this or that.
Yeah, great. Thank you.
Yeah, I'm going to jump to a couple of questions that came up, and I think Kannan, you actually addressed one of them. Really was about like sort of using telemetry as a way to detect earlier patient deterioration from a non-cardiac reason. But there are other ways that you can get to this, to the data that you actually need that isn't actually telemetry. So can you talk a little bit more specifically, Kannan, about like what those other options are, and how folks sort of collect that data to really understand like what are the pieces that we really need?
Yeah, absolutely. And I think the whole topic is fascinating. It really opens up a bigger topic, which is, what is telemetry, and what is this broader idea of patient safety while in-house going to look like in 10 to 20 years? I think what it's going to look like is telemetry units merging with rapid response units for just a continuum of span of care of trying to either not only detect deterioration so you can react quickly to it, but as the question brings up, how can you predict a deterioration? So a lot of the clinical prediction rules on clinical deterioration rely on not necessarily just telemetry, but rely on vital signs, heart rate, blood pressure, respiratory rate, various lab results. There are many clinical prediction tools that are well published and well validated. It's hard to predict, as Yogi Berra said, the future. So none of these rules are really that great, but at least they can give you a guidance as to this patient is at risk for clinical deterioration in the next 12 to 24 hours. So there are many pieces with prediction, right? One piece is, okay, can you predict it? And then two, having predicted it, can you do anything about it? And neither, the second part of that hasn't necessarily been proven out in the literature. But many EMRs integrate some of these prediction tools. And so just even looking at vitals and calculating clinical deterioration scores, I think is really useful. One just interesting anecdote on that, when people started sort of developing and validating these prediction tools, one of the strongest clinical predictors of clinical deterioration is if someone has an odd numbered respiratory rate, if it's 19 or 23 or 27. And the reason is because someone actually sat there and counted the respiratory rate for a minute because they were worried about the patient instead of rounding it off or estimating 20. So I think that's just kind of an anecdote that illustrates that there are other ways actually to get at this. And I think as technology matures and evolves, as artificial intelligence is able to grab more sophisticated indicators and really trawl the EMR, I think those deterioration tools and indexes will definitely improve. But they don't rest solely on data that comes off telemetry is the bottom line.
All right, Angela, there's another question that I'm going to direct to you from your research about is there data around this is from one of our attendees here. Is there any data around the percentage of time during their length of stay? Basically, the assumption is that if they're healthy enough to stop telemetry, that they are healthy enough to be discharged. But does telemetry extend the time that they stay in hospital?
There's only the one study that was looking at that, and that was for those respiratory patients. I think it's a great question, and I think it's something that we should be researching. My hypothesis would be that there is likely patients that some patients that will have their stay extended because they are on telemetry. And some of it might be the psychological burden of the patient as well. But I think also clinicians potentially may feel that this patient is more unstable or more unwell if they remain on telemetry as well. So, that's my hypothesis, that I would say that yes. I don't think it's all patients, but I think there's a subset of that population that will have an extended length of stay compared to patients who are not on telemetry that look exactly like them. But Kannan, do you have any gut reactions to that?
No, I think it's a really great question. And, it really gets to the philosophical question of what does it mean to be hospitalized, right? Now we have all these things, hospital at home as a potential. And I think increasingly where we're headed is you're hospitalized if you're at risk for rapid deterioration, such that being in the hospital setting is going to help you recover from that deterioration quicker. And so then that sort of gets you to the notion of, all right, well, how do people clinically deteriorate? And I think telemetry, heart rhythm disturbances absolutely are one of the big reasons why people deteriorate. But I guess it wouldn't probably be the only reason. I think a good example might be someone who has opiate overdose, right? Opiate overdose. It's typically not the heart that fails you, but it's your respiratory rate that fails you. So patient like that, they don't necessarily need heart arrhythmia monitoring, although the QT interval might prolong with a hefty dose of opiate, but they probably do need respiratory rate monitoring and maybe continuous heart rate monitoring. So that just kind of gets at the idea that, there are two moving targets here. One, our ability to monitor continuously many other parameters, like for example, respiratory rate continuously, that's sort of emerging. And then the other moving target is sort of that spectrum of moving the hospitalization outside the four walls of an actual physical hospital to be able to start delivering hospital at home. And even then, right, if someone's in a rural setting and it's only 10 minutes to get anywhere in town, and you have someone on continuous monitoring or some other type of monitoring, they could leave the hospital and still be quite safe if EMS can get to them in time. So I think it's an interesting question. I think it's a very insightful and open-ended question, and I don't think there's one clear answer.
Yeah, and my heart is just singing when you talk about respiratory rate, because based on the literature, it's a leading indication of patient deterioration, and I think it's not as well understood, and I think it's because it's been primarily an unautomated vital sign, right, that has been assessed historically. And there's lots of literature and evidence, to your point, around just not taking that rest rate for a full minute, but the richness of that data point in detecting patient deterioration is really vitally important. So I think organizations need to move to assess the needs of the patient, but look at continuous respiratory rate monitoring and heart rate monitoring as a standard of care, especially for a subset of the population.
Yeah, I totally agree. I think that's where we're headed.
Yeah, I agree.
I just wanted to ask sort of a last sort of another open-ended question about if there's something that, and I'll direct this at Kannan first, is something that you really want folks to understand about telemetry use and overuse and trying to make that culture change, what would be sort of like the key point you want folks to take away from our conversation today?
I would say start talking to people and just start getting, what we would call the voice of the customer. Just walk around your organization, talk to the nurses, talk to the technicians, talk to the physicians, talk to the ER, which probably has patients boarding, waiting for a telemetry box, and just start to understand, what are the pain points. And then once you understand what your local pain points are, some places it might be a bottleneck of not having enough monitor space, and you're thinking about an expensive capital expense to put one in, or some places might be not enough, telemetry beds or the timing of where telemetry could change. I think that really informs where people are going to be most open to change in this journey. And that starts to give you sort of an entrance point into where you can start to implement a change, and then just kind of keep talking to people. I think the data is really important, but really just understanding people's where they're at sort of on a day-to-day basis, it really gives you that platform for change, that learning burning platform that we think about whenever we talk about a change management project.
Yeah. Yeah, I think that lived experience is really important to really understand and then pull together those themes to really help. And the other population, Kannan, that I think they should talk to is patients.
Yes.
Understand their experience, and not only patients that are on telemetry, but patients who are staying in the room with patients who have a telemetry box, and just the impact of those alarms going off, right? It not only impact and the family caregivers, right? How do they think? How do they feel when a loved one is on telemetry? They come into the hospital and they've never had continuous monitoring, and all of a sudden now they're in there and they thought they were in there for something fairly benign. So I think those are important elements as well. And I think the other thing related to that changing and implementing things is, I think there's no silver bullet. There's no one thing. It has to be a multi-pronged approach around solving this problem. There's many solutions to the problem. And I think we've seen in the literature that it's mostly the EMR, it's mostly, training and education, but I think there are other types of solutions, and maybe some of those solutions don't exist today. But I think as hospitals start coming together and clinicians within that hospital and start talking about it, they'll start to identify ideas, and then talking to your technology partners to help solve this problem together might be really beneficial. But I do think there are many ways in which we can help to solve this problem. And to your point, I think it's not just the data, it's really understanding that lived experiences and those pain points. And obviously, I'm going to be biased here, the economics, the costs associated with it. I think that whole understanding of the whole picture and then start solving is the best path forward.
Yeah, I think that's right. I think the people that are really engaged in this improvement work, Angela, are largely people who kind of live in the middle of an organization like me, right? They're not necessarily on the front line. They're in either manager, director, or sort of vice president, but probably not senior vice president roles. And part of it is bridging what's happening on the front line, that lived experience, translating it into something that can be understood at a very high level, at the highest levels in the organization, and sort of driving that change forward. I think that's really important. Making that link between what's happening for individual people on a shift basis to what is important for the health of the organization, whether it's big picture trends like the Great Resignation, improving job satisfaction, hard dollars spent on capital outlay. I think that's so critical to really get the mass and momentum of the organization behind a change.
Yeah. Well, I just want to, we've had a great conversation today. I can't thank you enough, Kannan and Angela, for taking the time to share the research, experience, the insights, and just the whole idea of really thoughtfully thinking about that there is this overuse of telemetry, but we care about the patients. We want to make sure that they are safe and that we consider the patient safety while also addressing some of the issues with, nursing workflows and the burden of documentation and data on clinicians, shoulders. So I really think this has been a great conversation, and I really appreciate our audience for joining us today. We had some really good questions. They were also very thoughtful questions, and I can't thank everyone enough for being here today. So, and as we mentioned before, and in the chat, we do have a white paper that has a lot of Angela's research that we've referenced today in there. So there's a link there. When we share the recording, we'll also include the white paper link as well for all attendees, so that you can also do a little bit more digging on your own. And I hope everybody has a great rest of their day, and thank you so much for coming.